All right, welcome everybody to today's webinar, an overview of national pharmacare and key priorities. Before we get started today with the description of the webinar, we did want to start with a few housekeeping details. We will be going through the presentation and moderating a fireside chat, and we know that there'll be lots of questions that come out of our audience today. In order to have those questions addressed in the fireside chat or in the Q&A portion of the webinar, please type them into the Q&A function down on the main function bar at the bottom, rather than entering them into the chat. That allows us to ensure that we're getting to everyone's questions and making sure that the most popular questions are addressed throughout the content of the webinar. So, as we know, the federal government made headlines earlier this year with the announcement of a commitment to implement a national pharmacare program by the end of 2023. Details about the structure and implementation of the national program have yet to be decided, and given the impact on the pharmacy sector and patients, it's crucial that the pharmacy profession have a voice in informing the creation of the government's plan and understand the nuances of different pharmacare models and how they could be implemented within the province of Ontario. So I'll first introduce Katie Healis, who's the Vice President at Enterprise Health. Katie has worked with OPA in our government relations capacity for several years now and is our resident expert on healthcare policy as a political strategist. And she's an issues manager with a successful track record of running some of Canada's largest health advocacy campaigns. Katie started her career in the Ontario Minister of Health's office, where she was a key advisor on health policy, working with a variety of political campaigns at the municipal, provincial, and national level. At Enterprise, Katie's led national public affairs, government relations, and PR campaigns in all areas of healthcare, from mental health to hospitals and long-term care. And Katie will be moderating our discussion today. So welcome, Katie. Thank you so much for taking the time to discuss pharmacare with us today, and I'll pass it over to you.
Great. Thanks, Jen, for that kind introduction. And thank you for having me here today. Looking forward to this conversation. My job today is really to be the moderator of this conversation between Helen and Justin, who are the policy experts on all things pharmacy, pharmacist, and pharmacare. But before we get into that, I wanted to provide a bit of current context in the political landscape that we're operating in, because it's having a huge impact on what has happened and what will happen in the future. So to level set, we're going to start there. And I'm sure many of you are wondering why we're having this call today about pharmacare. It's a conversation that's been going on for 20 years and kind of stops and starts and stops and starts. So you might be asking, why now? Why are we having this conversation today? Why does it matter? And the answer is that in the last year, things have changed a bit. So we have a commitment now from the federal government, from the Liberal government and Justin Trudeau, to work together with the NDP government in Ottawa to come up with a plan and some next steps on pharmacare before the end of 2023. So this is part of the recent agreement between the federal Liberal government, the federal NDP government, to work together as a coalition government in Ottawa, or a government agreement in Ottawa, I should say. And one of the key components is pharmacare. So this is really for the first time that pharmacare has had a deadline on it. And while we don't know exactly what's going to happen between now and the end of 2023, we do know the pharmacare file is going to advance. So we're hoping to have a conversation today on where we're headed and what that looks like, and to get all of you engaged. Both because as pharmacists, you have really great expertise and you can help shape this policy, and we want to be a part of shaping policy. And also because we know as pharmacists on the front lines, you're going to be the people that are hearing from your patients when the government talks about or announces a pharmacare plan, and what does it mean for me and what does it look like for patients. So our job today is to help bridge that gap for you and provide a bit more information on what it looks like today and what it might look like in the future. So a bit of a primary background on pharmacare for those of you who are less familiar, but as I mentioned, this is a conversation that's really been going on for more than 20 years, but certainly at least 20 years. In 2002 was when we saw the first real report to government on pharmacare, and that was the Romanow report. After that, we saw not a whole lot of action. Government didn't move forward on too many of the recommendations from the Romanow report in regards to national pharmacare, and shifted their focus more so to bulk buying and purchasing. And that's where we've seen a lot of the actions and pauses, I should say, also on the Patent and Medicine Prices Review Board, or the PMPRB. I know you all know it lovingly as the PMPRB. So lots of conversations have focused on the last couple of years to that. That was until 2018 when we saw pharmacare come back on the radar. Eric Hoskins, a former Minister of Health in Ontario, moved to the federal government to lead a council looking at pharmacare and what a policy could look like for Canada. So I spent about a year consulting with Canadians what a Pharmacare policy program should look like, making advice to the federal government and really trying to drive that agenda forwards. That happened in 2008. It brought a lot of attention to the conversation, brought a lot of media engagement, it brought a lot of public engagement. But since that time, we haven't really seen much action. The government hasn't really committed to one Pharmacare program one way or another, but they certainly have collected a lot of recommendations and advice from policy leaders over the last couple of years. Throughout the last couple of years, and notably through the pandemic and 2020 and in between, there hasn't been a ton of conversation on Pharmacare. And to some extent, I think people say it fell off the radar. So last year, last spring, when we saw Justin Trudeau, our current Prime Minister, partner with Jagmeet Singh and commit to advance this policy, I think it came as a bit of a surprise, especially with the timeline to make progress. They say this broadly, but make progress on Pharmacare by 2023. So one of the questions I think we need to consider in talking about Pharmacare is why is this happening? Why is the government talking about Pharmacare? Why does it matter to them? And at face level, I think the answer is pretty obvious. It comes from a reality or a perception that too many Canadians don't have drug coverage or don't have access to significant drug coverage. But what I will say is, as the federal government has explored this topic more and more, I think what they're also finding is that's not really always the biggest issue. I think one of the biggest issues they see now today is the disparities in coverage across Canada. There are significant differences from province to province, different jurisdictions, different formularies. And there's also some emerging challenges and specifics to rare disease has been one that's been pointed out. So a lot of new rare disease drugs coming on the market, some of them are significantly more expensive. And again, it's creating disparities amongst Canadians who have access and who don't have access, as those who need access to rare disease medications and don't have coverage can come with a heavy price tag. I would be remiss if I also didn't admit that the Pharmacare conversation, like many healthcare conversation, also has an ideological bent. There are certainly some people who think that there is only one solution for Pharmacare, and that is an entirely publicly funded model. So a model in which the government pays for everything, all drugs, all medications, all services, and removes kind of what the public would understand as private from the system. So that ideology, as we see come up in conversations today, it's also apparent in the Pharmacare conversation and adds to the complexity of the policy and the reality of the Pharmacare landscape today, which, as we all know, involves multiple players, public, private, and various models across many, many provinces. So just looking back at some of the policy recommendations that have been made, they're very similar, whether you look at the Romanow report from 2002 or the Hoskins report from 2018. Some similarities include taking the first steps to better integrate prescription drugs into Canada's healthcare system, establishing a new national drug agency to control costs, evaluate new and existing drugs, and ensure quality, safety, and cost effectiveness in all prescriptions. And finally, establishing a national formulary of prescription drugs to provide consistency across the country, ensure objective assessments of drugs, and to contain costs. So when we talk about Pharmacare, those are predominantly the items that we're talking about when it comes from a federal perspective. As I mentioned, the Hoskins report, it came out with very, very similar recommendations, although I would say in 2018, there was a further emphasis on the rare disease area and a further leaning towards supporting a more publicly funded or a public funded first model. Since that time, we haven't seen a lot of movement on the Pharmacare file, with one exception. Last year in the spring, before the federal election, the government announced their first Pharmacare pilot project, and that's in partnership with PEI, where they have provided funding to PEI to establish a program of their own, which they're deemed a Pharmacare program, to close gaps in coverage and access to medications in PEI. They've kind of given PEI the ability to shape this program to their needs. So it's not necessarily a formal model and one that we might have thought or understood it, but PEI is also tasked with evaluating over the next 4 years, giving feedback and advice to the government on what worked and what didn't, and that could potentially be one of the things that sets the agenda for the rest of Canada moving forwards. Bringing us to today, and in context of the current agreement between the federal Liberal government and Justin Trudeau and the federal NDP government and Jagmeet Singh, they have committed to the following: to continue to progress towards a universal national Pharmacare program by passing a Canada Pharmacare Act by the end of 2023, and then tasking the National Drug Agency to develop a national formulary of essential medicines and bulk purchasing plan by the end of that agreement. A lot of words, a lot of commitments, a lot of vagueness in one sentence. So that is the complexity in which we're going to try to unpack for you all today. That's why I'm thrilled that we have Helen Stevenson here to join us. As we know, Pharmacare, access to medication, a critically important area of policy, but also a critically complex area of policy. So what we hope to do for all of you today is unpack that so that you can be better advocates as you and the OPA look to shape this policy. And also, so potentially in the future, you can play a role in supporting your patients and understanding what Pharmacare is and Pharmacare isn't. So with that, I would like to introduce Helen Stevenson, who's going to walk us through some of those complexities and unpack some of those pieces of what Pharmacare models could and couldn't look like, as well as some of those formularies. Many of you might recognize Helen Stevenson, but she is the founder and CEO of Reformulary Group. Reformulary Group is a healthcare company that built a proprietary evidence-based drug list, the Reformulary, an award-winning drug finder tool that provides Canadians with valuable comparative drug information and saves money for organizations' health benefit plans. Reformulary Group has a formidable data information and saves money for organizations' benefit plans. Reformulary Group has a formal data asset providing innovative and valuable insights into healthcare stakeholders and has recently launched the first of its kind tool to capture real-world evidence. I could probably go on for her bio for a very long time, and I think most of you know it, but I think I'll point out a couple more things of key importance. In 2018, Helen was named by Mars Discovery District as one of the 8 Canadian female founders who have a relentless pursuit of success in science and tech. And Helen is also, most notably, the former Assistant Deputy Minister of Health and Executive Officer of Ontario Public Drug Programs. So really excited to have Helen here today to walk us through some of these policy pieces. After Helen's presentation, we will open it up to more of a panel style conversation with Justin Bates as well, the CEO of Ontario Pharmacists. But first, I'd like to pass the mic over to Helen. Over to you.
Thank you, Katie, and it's a pleasure to be here. I'm just going to share my screen. I have a presentation I'm going to use to address everyone on the webinar. So what I'm going to go through essentially is giving you a little bit of background about the players in the system here in Canada. Talk about sort of Pharmacare and different scenarios that we've modeled based on our big data asset that we have. Compare those and then give you in one slide our point of view, and hopefully that can be a good basis for discussion or questions from the group. So just again, to give an introduction to Pharmacare and specifically to remind many people, or for those that aren't as familiar with the different players in approvals and pricing, I just will quickly walk through them. So as most of you probably know, Health Canada, so Health Canada is really our regulatory agency. They are the ones that do a regulatory review and approve or not drugs that come onto the Canadian marketplace. We then have provincial and territorial governments, many of which have their own drug plans. And so, here in Ontario, as I'm sure all of you are familiar with, it's the big Ontario Public Drug Programs, which has a multitude of individual plans. The largest of those plans is the Ontario Drug Benefit Program. You have the Patented Medicine Prices Review Board, or the PMPRB. The PMPRB has been in the news quite substantially over the last couple of years related to some reforms that were brought forward, and a small number of which were subsequently put into effect, but reforms related to the pricing and how the pricing of new medications on the market is assessed and whether that is deemed excessive or not. I won't go into a lot of detail about the PMPRB, but as mentioned, it was certainly in the headlines for quite some time throughout the past couple of years. Then there's the CADTH, or the Canadian Agency for Drugs and Technologies in Health. So this is our national organization that does drug or health technology assessments for the provinces and provides those recommendations specifically for the provinces, but which many other organizations benefit from. And then the Pan-Canadian Pharmaceutical Alliance, or PCPA, which is the sort of negotiating organization that advises or negotiates on behalf of the provinces and territories. So then just to highlight as well, and I know many of you certainly are intimately familiar with the publicly funded plans, but just to sort of level set in terms of specifically defining these. So as you would know, each province does have a prescription drug plan that's funded by the government. Those plans differ across provinces in terms of not only who they cover, so who are the beneficiaries, but also with respect to the, what they cover. So the list of drugs, but also whether there's co-pays or deductibles, etc. And each province administers its own plan. Then you have privately funded plans. And so you're probably very familiar with employer-sponsored plans. So many employers, unions, associations, etc., provide health benefit plans to their employees and their dependents. Those plans are typically administered by insurance companies or in some cases, third-party administrators. Plans like the federal plans, these are technically considered privately funded plans because they are either being funded by or mostly funded by the federal government, for instance, but they're privately administered. So they're also administered by insurance companies. Then, of course, there are many Canadians that pay out of pocket that do not have drug coverage or they're underinsured. So that means that they may be covered under a privately funded plan or a publicly one, but their deductible is very, very high or their copayment is very high, etc. And so we consider those as out of pocket, meaning they either have to pay all or a portion of their drugs out of pocket. So the dilemma in Canada, as we would characterize it, is that you'll see there to the left. So some people have nothing. Some people have good coverage and some people have unlimited coverage. In other words, 100% reimbursement of any drug or device, etc. So in terms of quantifying what we spend in those different areas, so in total, we spend about close to $37 billion. Publicly funded plans comprise about $16.5 billion. So again, those are the provinces, for instance. And then privately funded plans are $20.4 billion. And so the privately funded ones have actually increased more significantly in the past couple of years. And then within privately funded, just to remind you, there's the employer-sponsored plans at about $13.1 billion. And then people that really don't have coverage or are underinsured. And that's about $7.3 billion. So again, $37 billion, and then just narrowing in on that group of people that are paying out of pocket mostly, that spend $7.3 billion. So in terms of Pharmacare, one of the, it's been also in the news quite a lot is with respect to our prescription drug prices in Canada. So they are reportedly among some of the highest in developed nations. Now, our brand name prices are actually, having done a lot of that work back when I was in government, our brand name prices are actually sort of modest compared to, for instance, the US. Generic prices are higher. And so it is a mix, but compared to, many developed nations, we're still among the top in terms of pricing. There is really a patchwork of coverage. So as mentioned, some people covered through provincial plans, some covered through private plans, sometimes coordination of benefits, and then some people that are simply paying out of pocket. And so as a result of that patchwork, it really does leave a large number of Canadians with financial barriers in terms of getting the drugs they need. So the government laid out recently, as Katie mentioned, 3 foundational elements for developing a national program. So one was to develop the Canadian Drug Agency, as they've called it, to make decisions nationally and negotiate better pricing. The second is to have that agency develop a national formulary. And the third is to start a national strategy for drugs for rare diseases. So in terms of CADTH's role in that national formulary, again, Katie mentioned or referenced, the national bodies. So CADTH was actually created many years ago to coordinate reimbursement recommendations for new drugs. They do their assessments after a drug has received Health Canada approval. Typically, they have done their assessments when the pharmaceutical company has made a submission to CADTH. That said, there are quite a few manufacturers that have not made a submission to CADTH. We believe mostly because those drugs are typically more drugs that are reimbursed through private plans and not necessarily through public plans. But based on some recent reforms done by CADTH, they are going to start to proactively do reviews as well of drugs by manufacturers that have not made a submission. Anyway, all to say is they do quite rigorous reviews. They assess clinical effectiveness, cost effectiveness, and they also factor in patient evidence. The federal government did, as part of the Pharmacare initiative, mandate CADTH to convene a panel, and that panel provided recommendations. The report was released a couple of months ago, and really some of the highlights include, what are the characteristics that the formulary, a national formulary, should meet, how to implement that formulary, and also considerations around accountability, how decision-making is made, and really to ensure public trust in that national formulary. So the PCPA, as we refer to it, was established to really combine negotiating power among the provinces. And I do want to highlight that is that the PCPA only acts on behalf of the provinces. They do include some of the plans such as NIHB, which is the non-insured health benefits, or plans for First Nations communities, correctional services, the VA, etc. But what's important is that private plans are completely excluded from any negotiations by the PCPA. So this is really a public sector initiative. There certainly has been lots of, I'll say, advocacy by some of the big organizations such as CALIA, which is the Canadian Health and Life Insurance Agency, and that to really try to get access or some sort of leverage by the private plans with respect to what's negotiated through PCPA. There has been no movement on that to date, so I don't think that's there's any change there imminently. So when in the Hoskins report, really what that report was recommending was a national formulary with first dollar coverage, which means is you walk into the pharmacy with your prescription and the public plan pays from sort of, from zero, any amount for that prescription. And then when we talk about, again, back to the national formulary, there has been a report, the Department of Finance issued a report around if we were able to negotiate better pricing nationally, based on national pharmacare, that could lower public drug costs by up to $3 billion. There's lots within that $3 billion, I think, that would need to be unpacked. And certainly that may not just be with respect to putting pressure on the prices of drugs, but it could actually have an implication across the system in terms of wholesale distribution, pharmacy pricing, etc. So we don't have enough information, I think, on those kinds of details, but certainly the intention or the promise of that was around saving quite considerable amount of money. So we did some modeling. We do have a rather large data asset of prescription claims data from both governments and also private plans, so from insurance companies. And so what we did is we modeled 3 different possible versions of Pharmacare. And I'm going to go into each one of these in a bit of detail. So one, which is based on what's called an essential medicines list, which I will describe in a minute. A second version based on the CADTH framework. And then finally, based on the top DINs that are claimed based on our big data set. And what we did is we assessed the impact of each of those 3 versions and what the cost could be in transferring or in the federal government picking up coverage of those drugs. So let me first start based on the essential medicines list. So you may be familiar with this. This is a list that was based on what's called the Clean Meds list, which is based on a 2013 World Health Organizational list of essential medicines. So what's unique about or specific about this one is that this list is a small number of medications or DINs for a broad range of conditions. So you'll see there's at least 44 what we would call submedical conditions represented. So for instance, asthma, COPD, ADHD, diabetes, heart and blood pressure, etc. But there's a limited number of drugs for that broad range of conditions. So about 1,210 DINs that are in that list. Of note, there are many high-cost drugs that are not included. So for instance, no biologics, very limited drugs for instance, cancer and multiple sclerosis. So when we look at that 125 essential medicines, so based on that list, currently among public plans and private plans, so public plans spend about, for all medications, they spend about $15 billion, and private plans about 12.7. That has now, those numbers have increased slightly. But if we look at those 125 essential medications as a percentage of total spend, you'll see they represent 14.1% of the spend by public plans on all medications, and about 17% of the spend on all medications by private plans. So if the federal government were to now pay for those 125 essential medications, that essentially would relieve, or the federal government would pick up $2.1 billion worth of spend for public plans currently, and $2.2 billion worth of spend for private plans. So about $4.3 billion of spend that would cover, right, these essential medications. So that's scenario number one. Scenario number two is based on the proposed CADTH framework, which is essentially now, this is a large number of DINs for a small number of medical conditions. So 3,860 DINs, right, which is about 277 drugs for 3 medical conditions. So that's really significant. That's completely sort of opposite to the essential medications, which is a small number of DINs for a large number of medical conditions. So, you know, what's again important for this is the focus would be, it does include, you know, products such as, you know, continuous and glucose monitors. So diabetes features prominently, but as you would see, there would be a large number of medical conditions for which there would be no drugs covered. So what does that mean? So again, based on, you'll see the annual drug spend for public and private programs. So the CADTH formulary as a percentage of that total spend. So the CADTH formulary would represent 32.9% of the total spend by public plans and about 30% of the total spend for private plans. If the federal government were now to put in place the Pharmacare based on the CADTH formulary, that would cost them $4.9 billion for all the public plan spend current and $3.8 billion for private plan spend. So all told, that's just over $8 billion, or about $8.8 billion that the federal government would pick up and that public and private plans would no longer pay for. So that's scenario number two. Now let's go to scenario number three, which is essentially based on top DINs formulary. So we looked at, based on our own public and private data set, and it represents close to $10 billion of spend in Canada. We looked at the top 1,000 DINs by the number of claimants in both the public and private plans. So it represents this about 55 submedical conditions for private plans and 59 for private plans. And it includes, this list of drugs would cover a broad range of conditions that would include asthma, COPD, high cholesterol, pain, etc. And the coverage represents there are many covered drugs per medical condition. So this is sort of, so essential medicines was a small number of DINs for a large number of medical conditions. CADTH was a small number or a large number of DINs for a small number of medical conditions. And this is sort of the hybrid, a combination of both. That said, there are many high-cost drugs that are not included. Those are not included because this top 1,000 DINs is based on claimants and not based on spend. And so as a result, there would be limited coverage of drugs such as biologics, drugs to treat cancer, drugs to treat multiple sclerosis, for instance. There would be no coverage essentially of HIV/AIDS drugs because they're really, you know, that would be in the lower number of claimants. So what would this impact be? So again, you'll see there that common line in terms of the annual drug spend currently by public plans and then by private plans. And so the top 1,000 DINs as a percentage of total spend is about close to 56%. So So those total top 1,000 DINs would represent 56% of the spend made by public plans and 49% of the spend currently by private plans. And so if the federal government were to introduce Pharmacare based on a top 1,000 DIN list, it would cost them, and it would reduce the spend by public plans of $8.4 billion. And it would cost them and reduce spend by private plans of about $6.2 billion. So this is now a substantially higher spend if they were to base it based on the top 1,000 DINs. So let's just do then a comparison. So here is a comparison of the public plans. So again, these three different scenarios, the essential medicines list, the CADTH list, and then the top 1,000 DINs. So again, that essential medicine list represents about 14% of the total spend on the drugs. The CADTH list represents about 32.9%, and the top 1,000 DINs represents about 56%. So you'll see there again, right, what it would cost the federal government, which is what it would reduce the public plans, the reduction in spend for public plans, but the cost of the federal government. So again, that essential medicine is about $2 billion, the CADTH list is about $5 billion, and the top 1,000 DINs is about $8.4 billion. For private plans, you'll see there again that essential medicines represents about 17% of total spend, CADTH about 30%, and the top 1,000 DINs about close to 50%. And so the reduction in spend here is about reduction in spend for private plans is about $2.2 billion. So if the federal government were to pick that up, it's $3.8 billion based on the CADTH list, if the federal government were to pick that up, and $6.2 billion based on the top 1,000 DIN list, if the federal government were to pick it up. So what we also did then was a comparison related to those specific formularies and what medical conditions, what kind of coverage of medical conditions would they offer. So this is essentially comparing, again, those three formularies, if they were to be national formularies, and looking at the proportion of spend that would be covered for all of these different medical conditions based on those formularies. So I'm not going to go through each line, but rather highlight the red ones. So you'll see under the essential medicines list, and you may remember, right, small number of DINs for a large number of medical conditions. So you'll see there the large number of medical conditions where there would be DINs that are covered. There are two really highlighted on this list. So high cholesterol and substance dependence. So there are really two categories that are, which we would say sort of in terms of some of the top medical conditions, two categories where there would be no drugs covered. We then look at the CADTH list, and you'll see there are 4 areas. So there are 4 medical conditions where there would be no coverage of drugs, because if you remember, the CADTH list is large number of DINs for really 3 medical conditions. So that means that drugs to treat asthma, COPD, drugs to treat cancer, and that includes some of the, I'll call them not high cost cancer drugs, drugs to treat HIV/AIDS, and drugs to treat migraines, for instance. There would be no coverage, right? Under this scenario, there would be no drugs covered under the CADTH formulary. And then if you look at the top 1,000 DINs, so that's the column to the very right, there's really one medical condition, which is HIV/AIDS, where there are no HIV/AIDS drugs in the top 1,000 DINs that are by claimants, number of claimants. So just to remind you, that top 1,000 DIN list is by the number of claimants. So just to give sort of to sort of wrap that up, and then hopefully we'll get lots of dialogue in the chat. So Pharmacare, based on a variation of that essential medicines list, would actually provide access to drugs that treat a broad range of medical conditions And we would say at an affordable cost to government, right? It was more related to if I can just take you back here, it's about 2.1 billion and 2.2 billion, so about $4.3 billion. And so those, what would come from the private plans is about the federal government would then in that model pick up about $2.2 billion of spend, right, from private plan spend, which could have the positive impact of freeing up that money to enhance other benefits. Now, as most of you would know, that is really at the discretion of the private plans. That's not something we believe necessarily that the federal government could mandate. They'd have to certainly bring forward legislation but that is, I think, quite unlikely that they would mandate to that level, that a plan has to reinvest that in other benefits. And then finally, we really believe that government funds would be better spent, again, closing the gap on the uninsured and underinsured and addressing those needs, as well as addressing the needs related to mental health and expensive drugs for rare diseases. So, on that basis, we have not been huge proponents of Pharmacare. We have, however, been really strong advocates of this idea of closing the gaps, where people, again, either don't have any coverage or their coverage is not adequate, and to really then address those needs. And then also specifically, the areas of mental health, the pandemic has certainly highlighted that. And then also the whole area of expensive drugs for rare diseases. So I'm going to stop there. And Katie, I'm happy to hand it back and look forward to the discussion.
Thanks, Helen. We really appreciate your time and detail to walk us through this. As we've talked about, it's a very complex topic. So I think with that, we're gonna open it up into our panel discussion. And before we jump in, I do really want to encourage anyone listening today to please use the Q&A feature to put questions in throughout. I'll work them in as soon as we start getting them. So feel free to put forward your questions either to myself or Justin or Helen or others on the line. We're happy to address them. But just to start, I want to introduce Justin Bates, the CEO of the Ontario Pharmacists Association, who I'm sure many of you know. And Justin, we just heard from Helen a bit about, her final thoughts on what positive impact a model could have, but what the best model moving forward might be. But I'd love to hear from you on where you see Pharmacare today, and answer what problem or gap you think it could be helpful in filling.
Yeah, and I sort of go back to the outset of your comments, Katie, which I think were very germane to this conversation we're going to have now, and trying to determine what is the problem that we're trying to solve. And I think there is an ideological component to this. I think we'd be naive not to suggest that. And in particular, when we think about the political dynamic between the federal government and the various governments in power across the country, because we have a mix, right, between all three parties. And as we've seen with the daycare deal, and you've referenced PEI with Pharmacare, there is a model now to fill the gaps, if you will, in working collaboratively and customizing a solution that does that. It addresses where the pain points are on a provincial basis without necessarily creating a whole new bureaucracy that's going to try to manage this at a federal level. So I think there's a precedent. I think there's opportunities to definitely, from a principled perspective, align across ideologies, because as Canadians, and if we put that hat on as citizens, as taxpayers, we all have families. We all have some of us are patients. We help as caregivers to patients of our family and friends. The idea that in a Canadian universal, so to speak, system of our healthcare, that somebody would be left behind and either can't afford because of high deductibles or co-pays, or have no insurance at all, I don't think resonates well. I don't think there's any Canadian that would say that's acceptable, given our current state and thinking about the barriers to access healthcare services. There's so many other barriers, including financial today, with the lack of capacity in the healthcare system. We have to work collaboratively with all of the stakeholders, including governments of different ideologies and political parties, to try to bridge those gaps so that no one's left behind. So principally speaking, I think there's opportunities to work together to address those gaps and really target the investments. We think about rare disease strategy, oncology, we think about high cost drugs, and we think about the under and uninsured as being areas where, with the finite amount of resources, because at the end of the day, it's going to have to come down to how are we going to pay for this? And there's a lot of pushing that dollar around, whether it's the provincial budgets, healthcare transfers from the federal budget. At the end, the pot of money is coming from the same taxpayer. So we need to make sure that we efficiently spend that money in a way that gives value and a return on the investment. But I also think about a conversation I had with Dr. Hoskins when he was health minister. Actually, I was at a Council of Federation meeting in Winnipeg at a reception, and he was very generous of his time. There was multiple people at the table. He sat down and, with absolute conviction said, we are going to get this done. And I asked him, I said, that's great. I really love the passion and where you're coming from and the perspective. But what does this mean? Like when you say we're going to get this done, are we creating a whole first dollar adjudicated system? Because government doesn't buy drugs, right? So there's a whole process here that has to be thought about. And it wasn't clear that there was, as much as there was conviction on the philosophy and ideology of national pharmacare, and this is going back into probably 2015, 2016, the definition of what it is was where we were getting into a lot of the challenges. So what exactly is national pharmacare? Helen, you've done a great job of articulating some of the potential options in terms of, which drugs would be covered and who would pay for them and what the net benefit would be to each of the stakeholders. But I think that key question when we talk to the Prime Minister's office and we talk to some of the key political stakeholders in Ottawa, even they struggle to understand beyond the philosophy of let's get everyone coverage and national pharmacare, how it would be implemented. And that's where our role comes in. I think collectively with private plans and pharmacy stakeholders, we need to help shape that in a way that isn't going to introduce unintended consequences, thinking about less coverage, not, we don't want a scenario where people have less coverage, or we introduce risks into the supply chain, into our domestic capacity around drug shortages. So we need to be, at the table with credible information, with the data to get this right. But I do think there's a role, and I do think we need to have some form of a solution beyond the status quo.
That's why we're having this conversation today, to try to get ahead of this and shape that policy. So Helen, you answered this question a bit in your presentation, but I wonder if there's anything that you want to pull out and focus on specifically in terms of, we're talking about the gaps that might exist. Based on kind of your research and your experience, is there a specific gap that Canada should be focused on when it comes to medication access? Like, is there an area where there's, alignment or clearly an issue where we could really focus and, to Justin's point, make the best investment in closing that gap?
Yeah. So absolutely. And we are I'm a big advocate of closing the gap and not, blowing up the current system and trying to create a new one. And so what I think is important, we hear lots of, stories of people that have no coverage whatsoever. I think that's, those are the targets really in from my perspective that we should be focused on. People that either have no coverage, people that have, again, that area of underinsured, which means they may have very little coverage. Or if we look at, for instance, that expression, the gig workers, there are a lot of communities of group where they really have no access to coverage. And I think those are the ones where, the government could have the greatest impact and not, in a manageable fiscal way. Because if we, again, blow everything up and rebuild a system, not only do I respectfully not have confidence that we'll get it done in a timely way, but I think, it could really drive, far greater cost than is currently spent by plans across the country.
Yeah, it's a really good point, a really good lead in to our next question. So I think we can all agree that if Pharmacare is successful, we hope that everyone has access to medication they need. I think we could probably summarize it that way. But you guys have both alluded to some potential negative impacts of various policy models or programs. So Justin, maybe if you want to start and just talk about what some of those impacts specifically to, whether it's to patients or to pharmacy or to pharmacists, could be if we don't get this model right. And Justin, if you want to start with that one.
I think absolutely we need to look at unintended consequences, risks and benefits, and what, at the end of the day, what we're trying to achieve, right? So if we go with the central principle that no Canadian should be left behind, that we want to complete the plan, address the gaps that exist, which vary across the country because provincial jurisdiction is healthcare. So all of the policies, reimbursement are largely driven at a provincial level. And there are provinces that have what they would consider to be Pharmacare, right? I think of BC, Quebec, Ontario to a certain extent, although each one has slightly different criteria of eligibility, thresholds for income, of what qualifies and what doesn't. I think the patchwork that Helen has mentioned has worked to some degree, but does leave that, 7.3 billion is a number that comes to mind, right? That you had in one of your slides about those are the out-of-pocket expenses, those that don't have coverage. That's where I think we need to focus and not try to reinvent and create a whole new let's call it a structure and framework around this in terms of, yes, there's a role for getting value for money on the price of drugs, and there are existing structures to do that with the PCPA in particular. So I think we need to really understand what the Canadian Drug Agency is going to do. How are they going to will they replace that structure that's seemingly worked well, depending on one's perspective, but definitely as a collective of the provinces, because the federal government was seen as not taking a lot of action. The provinces got together, created this, and I think they've invited the federal government into that structure now. So what role does that have? And then from an administrative perspective, Helen, you mentioned by creating this, are we adding cost and added complexity to how we the whole process. When I think about the dental care program, have some concerns about that, because in the timelines they're actually talking about providing some of the adjudication and administrative components, which would be very complex to implement with the provinces. And not all the provinces are in agreement with this, right? So there's at least a handful of provinces that don't want the federal government involved beyond a funding scenario. So if you put enough money at it, as we've seen with daycare, sure, the provinces will listen, but because you're reducing our expenditures. But I think there's a fine line there between funding and filling gaps and targeting investments to essentially setting up a whole new infrastructure that's going to add potential costs and delays for product listings, for coverage amounts as well. So my thing is, I want to make sure that the Canadians who have private drug coverage, that enjoy the coverage that they have, that have access to more medicines, don't lose that coverage. I think that would be a significant step back. We need to make sure those plans are sustainable. I think that's a key pain point. But there are solutions there to do that without blowing it up, and making sure that, a Canadian can get access. So government steps in as a first dollar program for those that are either underinsured or uninsured. But a lot of this doesn't factor in how dependent the whole system economic model is of pharmacy and other stakeholders. So if we're going to have a conversation about like the whole cost and pricing conversation, we also need to make sure that we consider the fact that pharmacists and pharmacy professionals are compensated for the work they do. Right now, we know there's high dependency on the product and the drug transaction, but there needs to be a parallel conversation about sustainability of our sector, making sure there's transparency there and fair and reasonable reimbursement, so that you don't have a downward impact on the pricing discussions, and at the same time can achieve drug coverage for all Canadians.
Thanks, Justin. Helen, I wonder if you want to add anything to that in terms of other impacts that you might be worried of if we move forward with the Pharmacare model that's maybe not best suited for Canadians.
Yeah, I mean, so yes, and I want to say too is I've sometimes heard in the past and probably I'm not sure if Minister or former Minister Hoskins, but it was the idea of sort of going back and fixing what Tommy Douglas created in Medicare, and it just sort of my view would be that shouldn't be the reason that we're doing Pharmacare, right? Going back just because we didn't quite get it right at the beginning, right? We're advanced now decades ahead, and we've got a system that has been built out, albeit not perfect, and a patchwork, but it just strikes me the importance is really to focus on, the system and the infrastructure we have now, and not try to, really break that apart. I mean, the other thing is, and not to be sort of cheeky about it, but I think governments are not great at building IT systems. And so that concerns me greatly, is the idea of having one big system where now the government embarks on building a new IT system to adjudicate all these claims, right? Which is possible that they could, undertake to do that rather than using existing claims systems. So that's certainly, one comment I make. I'd also make, I think pharmacists have a very unique position in the system because you're both a profession and you're a business. And so from that perspective, right, there's this dual role that I would advocate is, not like among other healthcare professionals, not as sort of dominant. And so, from a pharmacy perspective, it's important that the sort of potential impact of Pharmacare could have a dramatic impact on your business. On the other hand, you are an essential part of making sure it works. And so from that perspective, I think it's wonderful that you're driving this discussion, because I do think, right, you're a key part of the solution, but yet you could also be, impacted, by depending on which way the government may land.
Yeah, that's a great point. And with that, we've got a question from one of our listeners today. And the question is there any sense of which option of those presented today might be most likely, or that the federal government might have the highest appetite for? So I don't know who wants to tackle that question first.
Helen, I think that's square in your camp based on your presentation.
You have a crystal ball behind you, right?
Yeah, I know. I mean, you probably have a better, finger on the pulse of the federal government. But I mean, I would have thought, sort of based on the amount of money that has been spent, during the pandemic, and sort of, I'm hopeful that the Liberal government has some, in the NDP government, there is some awareness, right, of the massive deficit we're in. I would have thought that either that, I think a CADIF formulary, while that obviously they may have a vested interest because it's through one of their own organizations, the challenge with that is some of the medical conditions that are covered, there are a huge number that are not covered and yet will impact, people who are underinsured. So I would have thought the idea of an essential medications list that is, providing a baseline that is a broad range of a small number of DINs, broad range of conditions, is the most likely and the most affordable. It's going to reach the largest number of people at a, sort of manageable cost.
Mm-hmm. Justin, anything to add to that?
Yeah, I mean, the national formulary is one component, or could be one component of national pharmacare, but there are other ways to tackle it as well. And it would have to be a more individualized conversation. And it's going to take, let's say, stretched thinking politically, and more bold thinking and risk-taking, right? Because, we see in the context of Ontario, even the mere mention of private, and when we talk innovation, we talk about different delivery mechanisms, not so much who's paying, and that, it creates a lot of discussion amongst various groups about, well, we can't even have that conversation, right? So if we're going to think about how to solve this problem of underinsured and uninsured Canadians, then we need to be open to innovative solutions. There is a technology component to this. There is a funding component, and the way that it's set up now with the health transfers is actually prohibitive. It doesn't allow, it prevents the kind of discussions that need to have to happen by province with the federal government to customize a solution that it deals with the gap, because the gap is different in BC than it is in Ontario. And we often hear that your postal code shouldn't dictate whether you get coverage for a cancer medication or something. But in a universal principle that we have in our healthcare system, it's kind of unacceptable. I would suggest that we have that still to this day. And some of those gaps have been reduced. The national formulary would help in that respect. So would a rare disease formula and oncology formulary and targeted investments. But to me, it's going to come down to the magic of negotiation, of looking at things like the current Pharmacare deal with PEI, how they approach that. It's going to daycare as an example, and not necessarily trying to be a panacea and solve every problem. This is a very unique situation with healthcare. And as we've seen, there's bigger issues than just funding, right? There's access barriers, there's an equity or lack thereof, discussion as well across the provinces that the federal government has a role in. But we need to be pragmatic and practical. And to Helen's point, I mean, the system is broken. There are good things that are happening. We are in a massive deficit and debt. So it just makes sense to get away from some of the ideological components of this and really focus on solutions and being practical. My question to you, Katie, would be, with a federal government that's in a minority, with two parties that maybe are more closely aligned ideologically than they were before, but how real can this coalition stay together? And what's the expectation in this Pharmacare Act by the end of 2023? Because that's a very short window. You're not going to come up with massive change in that period of time. So I don't think so, I mean, practically speaking. So what can we expect to see in a Pharmacare Act, and will this coalition last long enough to get there?
I'll start with the second question first, because it's the most difficult. And I always advise against political predictions. Hard to say if the partnership between the Liberals and the NDP will last its full tenure. They had committed to work together until 2025. Will they reach that full term? We don't know. So far, it seems like generally they've been able to work together and have committed to continue to work together. I wouldn't be surprised if they didn't reach their full tenure, but it would be my suspect, based on how things are going today, and things can change quickly, that no one is quite ready for a federal election, and the partnership will continue at least over the short term. So then, to answer the second part of your question, is if this partnership continues and thus they have to make some type of progress on Pharmacare, what does that look like? That's the $1 million question. I think the closer we get to 2023 and the longer the term that the policy work hasn't happened, that federal health agencies aren't involved, that provincial negotiations don't start, the harder it is to do anything too substantive. So I think in that case, it becomes more and more likely we're seeing more of what we've seen in PEI with pilot cases and models where you're supporting provinces with funding to help close the gaps. Now, that said, that isn't ideologically aligned, certainly with where the NDP has stood and been very clear previously that it should be a public payer, first payer model, and where the Liberal government has kind of shifted between. So to be honest, time will tell. And the biggest factor here, I think, is the provinces. The provinces at the end of the day have to deliver whatever a Pharmacare program would look like. So until those conversations really start, I think it is really hard to predict. We saw many of the health premiers meeting over the last couple of days, not all of them, but at least Ontario and the eastern provinces meeting, talking about healthcare issues. Right now, I would say they're extremely focused on COVID-19, surgical backlogs, hospital closures, long-term care, those pieces. Pharmacare isn't even really making it to the agenda. So I think the other challenge they're going to be up against is getting the space to have policy conversations that are needed around Pharmacare. So for those reasons, I don't think anything is happening too quickly. But I do think this conversation will pick up over the next couple of weeks and months. We have another question. I think it ties back, Justin. You brought up some of the other provinces and what they're doing. So this question is specifically about the RAMQ style program. So obviously the program in Quebec, where the National Pharmacare requires mandatory coverage of all population, either within the public program or a private payer plan, with private payer plans required to cover at least all of the drugs in the public formulary and the same reimbursement level. Do you think that this leaves sufficient room for both public and private payer plans to exist? And maybe I'll summarize that a bit to say, do we think that the Quebec model is a good model for the rest of Canada, and should it be looked at?
Maybe Helen, you can start with that,
Sure.
being involved in the private plan side.
Yeah, and in full disclosure, that's a colleague of mine who's listening in, but he didn't tell me he was going to float the question. So I'm going to take that as this is an objective answer. I think the Quebec model has some very interesting components to it. My personal view is I wouldn't take it exactly, that RAMQ style program exactly as it is structured, and partially, as he mentioned, right, this dynamic of private plans being required to cover it, that I understand. But the problem is in some cases, let's say the Quebec criteria for certain drugs, et cetera, we would suggest could be more, could be sort of have more detailed criteria. And so there are some drugs that private plans are required to cover, right? Some very high cost, for instance, drugs for rare diseases that wouldn't typically be on a private plan formulary, but again, have to be covered because of RAMQ. The idea, though, of having kind of a minimum requirement in terms of what should be on that list, I actually think is a really interesting approach for on a national level, and perhaps in the context of a kind of fill the gaps model, or closing the gaps model could be what is introduced. I'll also just sort of on that note too, make a quick comment too, in full disclosure with respect to what we do. We manage our own formulary. So I just want to, and we manage it across the country for plans in every single province. And I just want to, put out one, comment related to that is, in managing a formulary and essentially reimbursing drugs that either work better or work the same and cost less, and reimbursing other drugs at a lower level, we've been able to drive substantial savings. So I mention that because in the context of national Pharmacare, this idea of introducing different reimbursement levels based on different drugs can generate considerable savings while still sort of, having a fairly large, robust formulary. And so I think it's not something that is on the radar screen of the federal government. We're one of the few that has a formulary like that. But I do think the formulary itself is such a key part of this, and not just kind of the big list, but also the dynamic and sort of incentives to people to take drugs that, again, work better, or for instance, generic drugs feature really prominently on ours as well. Not just, but just to highlight that. So just not to forget that the value of having a really well-managed formulary.
Yeah, and that begs a question, Katie. How is the government going about consultations with private plans, with pharmacy, and is there a formal process to gather that feedback to make sure they're hearing the different perspectives and helping to shape whatever they define eventually as Pharmacare?
To this point, there isn't massive public engagement on the Pharmacare piece specifically. There's been, I think, a lot of focused online engagement on PMPRB in the last couple of weeks and months. I'd say they're probably relying on the consultation that they did in, back a couple of years in 2018, where they did have national consultation through the Pharmacare Council. But I think we all know the world has changed a lot since COVID-19, and some re-engagements are probably necessary. So while they haven't come out with too much formally, I do understand that there are conversations starting to happen with the new minister, not that new anymore. I guess he's about a year into his role, but conversations with the health minister on this topic and with stakeholders. So I think, as we've talked about, these conversations are starting to pick up, and hopefully, I think what we're all talking about is that it leads to some fulsome conversations on real solutions focused on the actual problem.
It's interesting that our health minister federally is from Quebec. So maybe some of those lessons learned and modeling might enter into the conversation. But I think it is important that we have a seat at the table, and our members need to be aware of the, what could be a very positive development in terms of fill the gaps, getting more coverage, thinking about patients first and in access to drugs, but also the economic impacts, because it does represent a potential risk if we don't also include conversations around the sustainability of the sector for both private plans and pharmacy. I think those are very real discussions. And, we know one of the pain points at the pharmacy is managing drug coverage, right? A lot of time is spent navigating that on behalf of patients. And I think there's for some within our membership, there's this automatic reaction that, well, National Pharmacare is going to solve that problem. And it might simplify drug coverage, but at the same time, it might introduce a whole host of other complications that we need to consider. And at least we need to understand. We need to have the conversation to understand what those implications are.
Absolutely. Helen, I've got two kind of upcoming questions, formulary related, that maybe are best suited to you. So the first one is, and Justin, feel free to jump in here if you know too. Has anyone done a deep analysis and compare different provincial formularies?
Yeah. I mean, the answer is yes. I'm sure there are many. I mean, we certainly do, and we do it on an ongoing basis, but I'm sure there's lots of organizations that do, right? And really there's, the differences are in the formulary itself, but also who's eligible, right? Who are the beneficiaries of the program? Is there any kind of income testing? And then of course the RAMQ component as well. So yes, it is complex. If anyone has a really targeted question, you're welcome to email us and we can help you navigate. And then do you want me to go on to the other one, Katie?
Yeah, so the second question, just for our audience,
Yes.
is about biologics. So given that biologics are becoming more prominent in treatment of many conditions, how do you see their coverage be included in the discussion?
Yeah, so that is an excellent question. And I will say we have, our team did some pretty extensive work around biologics. We did it last fall, and it was really around the use of biologics, the biosimilars coming on the market. But as many people probably know, I think I'll get the number right, like 40 biologics and 11 indications. So this is now there's a huge use across, among Canadians. And, part of it is there's also a pretty significant difference in the evidence for certain biologics for some conditions and in the pricing, in the cost. And so I think, yes, I think coverage, will be included in the discussions. If I can just mention, right, in the analyses I provided, an essential medications list is not providing coverage for biologics, but neither really is a CADTH list. And so, but it is really important to include these, because while there are certainly treatments that people could try first as a kind of step therapy, these are really, important treatment options for people with, arthritis, with Crohn's, etc. But what is important, again, is we would say respectfully that the work is done in terms of looking, what are comparative, which one should be tried first, and not just sort of covering all of them. There's a real opportunity here to create that kind of efficiency.
Justin, anything to add on either of those two pieces?
No, I completely agree. I think when you look at the biosimilars uptake and the pipeline, there are clear challenges there, and we can't shy away from those conversations. There needs to be efficiencies, but also we need to look at it from what's appropriate clinically. So there's the financial component to that, and then there's the clinically appropriate therapies, and it's always the balance, as you will know, Helen, from your time as executive officer, looking at value for money, looking at coverage. Making some of those tough decisions is probably the most challenging of any program, be it private or public. But the whole area of biologics is something that we know in Ontario. There is the proposal for what we'll call forced switch policy that's already in place in Alberta, I think in BC. Whether that's the right approach or not is to be debated. But we also have a change in the pipeline. We're going to have more of these specialty medications that will be injectable or oral, like we're seeing with oncology. So specialty pharmacy is going to evolve too. It won't just be clinics, it will be your community pharmacy involvement as well. So that will also change some of the dynamics and costs related to it.
So the next question here, and just going to encourage others, if they have any questions, please get them in now, as we have a few minutes left. But the next question is disease prevention on the radar, i.e. meds for preventative care? Is that coming into this conversation at all from either of your perspectives?
Well, I would say not enough, not nearly enough. And I think that's probably a bit indicative of our health system, right? We're all about, when you think of, right, the news every day about the emergency rooms, right? We're all about sort of, people flowing in through this acute, care channel. And, could we have, that's sort of from the, I'll say from, care in the community. Could we have prevented that with, using other, clinics, for instance? And I will say I have a very personal experience with a family member in the hospital. Hospitals operate like offices, 9 to 5, Monday to Friday, and our health system and our own health, right, is 24/7. And so, just to circle back on, I think, preventive, I think we don't nearly do enough. And we also don't have, so we probably as Canadians don't think of it and do enough of it, but we don't have access to services that would enable us to do that. So, that could be, an opportunity for pharmacy, where their advice is just, so incredibly critical to the health of Canadians.
Well, it's a great jumping off point from a lot of what we have talked about, both in the media and through our channels of negotiating with government and coming up with solutions to help address the public health crisis. And I always position it as not just about pharmacists. It's all healthcare providers need to be practicing to the maximum of their expertise and education. We need to unlock access to community health-based services, home-based services, which include wellness and prevention, as well as treatment for acute and chronic conditions. When we think about the backlog of chronic conditions that have been unmanaged, that's potentially our next healthcare crisis. Those individuals will present themselves at some point to a doctor, to the hospital, of which we already have capacity constraints. So for me, it's always about, right person, the right place at the right time, to remove the bed blockers from hospitals so that your hospital bed's going to be occupied, your doctor's office chair will be occupied, but you want it to be the right person. If they can be served more efficiently elsewhere in the system, then we need to move on those investments. And we've seen some degree of movement there with prescribing authority, with nurse practitioners, et cetera. But there's a lot more that can be done. Access to a GP is still challenging, and you don't want acute care, unless it's an emergency, being dealt with in a higher cost institution like a hospital. But we're still very driven by the traditional care paths. Even from the mentality of the healthcare providers to the payers. I mean, we haven't really been innovative and thinking outside the box. And you can see that discussion very alive right now in Ontario. And I mentioned earlier, as soon as you start talking about alternative care models, you get that initial reaction that, well, we can't do that. And I think that's unfortunate. I do think we need to preserve what's good about the public system and enhance it and invest in it. But there's different ways to deliver care that we have to look at if we're going to have a sustainable healthcare system.
If I might just add something to that too, Jess and Katie, and it's something from where we sit and what we deliver in, again, this big formulary is when we're, engaging with, so our model, right, is to work with employers and associations and unions, right, to follow our formulary. And what's interesting is, I'm going to say the most common question to us is, we're related to drugs and, potentially considering what we would consider to be a preferred drug. The question is, well, doesn't my doctor know best? And I can tell you, I literally in the last 10 years, I've probably said it thousands of times, your pharmacist is the expert on drugs. Sure, your doctor knows your medical condition and knows sort of the health, and so, on that note, I think it's, for pharmacy, really that, at an individual level, there's probably many Canadians that know that, but I think on a global level, right, really the importance of pharmacists, how critical they are, not to mention, I'd advocate that in many cases more accessible, much more accessible, how important you are in this system, and especially right in this big Pharmacare discussion.
Well, that's a really perfect segue. Thank you for that to our kind of our last question. And Justin, maybe if you want to tackle this first. So given the importance of this conversation and the expertise that pharmacists can bring to the table, how should pharmacists be engaged? How do we support this conversation? What can people listening on this call today do to engage in this conversation?
Well, this is the first step, is understanding exactly what the models are that are being discussed, a risk-benefit analysis of each. And Helen, you've done a great job in unpacking that for us and looking at all sides of the debate, because we have to understand what problem we're trying to solve and what are the practical solutions, and then unpack that a little bit further to look at, how does this impact patient care and access, and particularly coverage of drugs, because some of the things that have been discussed, at least at a high level federally, could actually impede coverage, right? Introduce more cost and barriers. So we want to make sure we avoid that. And I think coalescing around a set of principles that we can all agree on. We may have differences of opinion on, solutions, but if we're talking about solving the healthcare crisis that is continuing to get worse, drugs are a big part of that. We need to make sure people have drugs for wellness, for prevention, for treatment. And that is a central tenet to any discussion around national pharmacare. The best case scenario for us is to be at the table with our partners in private plans and public plans, federal government, to highlight and emphasize the role of pharmacy, the impacts that each model will have to our sector, looking at other models for reimbursement that would be in a way less dependent on some of the downward pressure that we're seeing with a deflation on the price of goods, and open up more opportunity to provide these types of community-based services in a fair and fair and reasonable way in terms of reimbursement. But at the end of the day, we need to have a voice. We need to make sure that pharmacy is represented and that we're part of the solution and that we have solutions going into those discussions.
Helen, what about you? Any parting words or final advice for Ontario's pharmacists?
To reiterate what Justin said, the importance of being part of those conversations and really also, right, what you offer to Ontarians in terms of, access to great medication advice, et cetera. And I would just reiterate that.
Fantastic. I'm going to maybe summarize just a couple of the points I heard from you guys today, because I think you've left listeners with a pretty clear summary. And first and foremost, it's a caution to government, a caution them to look at the problem and to address that with real solutions that are targeting those actual gaps and to be as practical as possible in those solutions. I think there's agreement that what we're trying to do is ensure that everyone has access to the coverage they need, but at the same time, making sure no one loses coverage as a result of any Pharmacare model. We heard advice about looking at other provinces. I think there's some areas of other models in various provinces that might work really well, maybe other areas that don't, but a good start is looking at some of those models we have and what's working and what could be improved. And then finally, loud and clear from you both that what's important is that pharmacists are at the table. Pharmacists are expert in this area of policy. They're experts in patient care and medication. So ensuring that pharmacists are at the table as we see what's to come on Pharmacare policy in Canada. And with that, I want to thank Helen and Justin for making my moderating very easy, and thank everyone listening for the great questions in the chat. I hope this is a conversation that we can continue. I think it's going to pick up over the coming months. So you heard it here first, and we look forward to reporting back to you on that. And with that, I think I'm going to pass it back to Justin just for any final closing remarks.
Well, I want to thank Helen for your contributions today and bringing forward all of that analysis and data that helps inform some of the potential solutions and where we might end up in those discussions. I think the key is collaboration amongst all the stakeholders, but also you bring a unique perspective of having been on the public drug program side and also now innovative in your business model and being in the private plan space. So that's unique. And I think our members value hearing from your different perspectives. And in general, I think awareness is important, raising awareness with our membership that these things are coming, that there is a clear shift in thinking around national pharmacare, that something's going to get done. Right. We've kind of moved past the 20 years plus of discussions around this, and that can be a good thing. I think we can turn this into something that can tangibly make a difference in barriers to access and drug coverage in particular. And we should see this as a positive thing if we can help shape it in a way that reduces or mitigates any of the risks or let's say unintended consequences, then that's a positive. And the fact that we're having these conversations, we can bring that up to our discussions with the federal government and our other partners, Canadian Pharmacists Association and others that are engaged on a more frequent basis with the federal government. So we're here to listen, we're here to understand and come up with solutions. And it's been a great opportunity to at least provide some of the initial thinking.
And with that, if we have no further questions, we will conclude today's webinar. Just a reminder that should anyone have any practice-related questions, including those that brush on the topic of Pharmacare, you can submit them to our practice support network at info@opatoday.com. We look forward to having future conversations as this important initiative evolves and moves forward, and looking forward to hearing more of your questions and encouraging all of you to take some of what you heard and learned today and apply that to your communications with patients, other healthcare providers, and other key stakeholders as you move forward in talking about Pharmacare, because our voice will be critical in ensuring a successful implementation of one of these programs as we discussed today. So with that, we'll allow everyone to reclaim about 10 minutes of their day. I don't see any further questions in the Q&A, and thank you very much for attending.
Thank you.
Thank you.
Thanks, everyone.
Take care. Bye-bye.